In the last part of our talk, we'll start with the movement disorder. So we'll talk about Parkinson's disease. So what's Parkinson's disease? Parkinson's disease is a chronic, progressive, and disabling disorder that are characterized by both motor and non-motor symptoms. And the pathophysiology due to two major underlying findings. The first is loss of pigmented dopaminergic neuron of the substantia nigra and the presence of Lewy bodies and Lewy neurites. So the loss of dopamine is predominantly affecting the substantia nigra, and approximately 60 to 80% of the neuron are lost later on before the motor signs started. So this is the very complicated basal ganglia thalamocortical circuit that causing the underlying pathophysiology of the movement disorders. So what are the symptoms of Parkinson's disease? So as I mentioned before, we have the premotor, non-motor, and motor symptoms in the form of constipation, anosmia, REM sleep behavior disorder, depression, mood, cognitive, autonomic manifestation. But the most important is the cardinal motor symptoms of tremor, rigidity, bradykinesia, postural instability, and gait disorder. So the clinical hallmarks start with bradykinesia, which is difficulty in terms of stoop posture, forward tilt, slow in movement, and this is the classical posture for the patient with Parkinson's disease. Mask faced, so it's a wide-eyed stare, immobility for the mouth, resting tremor, and it's a slow 4 to 6 hertz, like a bell rolling movement involving the elbow and the forearm. And sometimes they result in from the shuffling gait, which is a short and small steps, resulting in frequent falls. So according to the diagnostic criteria, so bradykinesia is the most important, or the initial manifestation with the slowness of initiation of voluntary movement with progressive reduction in the speed and the amplitude of repetitive actions. And with that, we need at least one more symptoms, including the rigidity, resting tremor, or the postural instability. And if we have any of the other red flags like repeated stroke, stiff head injury, encephalitis, oculogyric crisis, all these are an exclusion for Parkinson disease. So how do we treat these patients? So the gold standard in treating the patient is levodopa for a dopamine replacement. So we start with levodopa, carbidopa, and usually it's help in the bradykinesia, rigidity, and it has a variable effect on the tremor. And we have also the dopamine agonist medication. We have a group called COMT inhibitors and MAO-B inhibitors. Also at the end, we have the anti-NMDA or the NMDA antagonist. So the strategy in early Parkinson's disease, we start with levodopa, carbidopa, and as the patient responds, we might initiate other medication with it. In advanced Parkinson's disease, the higher the doses, it might induce dyskinesia, or the treatment cause levodopa-induced dyskinesia, and at that time, the patient might require surgical treatment, which is deep brain stimulation. So essential tremor is defined as involuntary movement that is rhythmic, regulatory, oscillatory, and it manifesting or in essential tremor, usually it comes bilateral. So and in addition to being bilateral, it's more in action or with the movement, but it's less to occur during the rest. So when we are taking the history, so we ask the patient about, can you tell me more about the tremor? What type of tremor? Is it noticed with the action or during the rest? Is there any specific hand, for example, a specific task that might provoke this tremor? And the essential tremor, as I mentioned, is the whole feature, or the classical feature is a kinetic tremor with the daily activity. And it's usually autosomal dominant inheritance with complete penetrance. And it's causing a difficulty with handwriting. So here we will have the different, to differentiate between essential tremor and Parkinson's disease. So essential tremor is more of kinetic or postural, more than rest tremor. Parkinson is rest more than action and postural tremor. It's involving hand, head, and voice tremor. It is task specific or position specific, like writing or orthostatic. It's affecting the writing or drawing. Here, it's more in resting and associated with in Parkinson's disease with rigidity, bradykinesia, postural instability. In essential tremor, it improved with alcohol, beta blocker, primidone, and topiramate. In Parkinson's disease with dopaminergic drugs. So the treatment, as I mentioned before, the beta blockers, propranolol, primidone also can be helpful. Other topiramate, gabapentin, and benzos can be also helpful. Myasthenia gravis. So we'll talk about myasthenia gravis. Myasthenia gravis is an autoimmune disorder that affecting the neuromuscular junction, and its prevalence around 1 in 1,000, and it affecting all ages with the peak in younger women and older men. So what's the pathophysiology underlying neuromuscular junction? So this is the normal neuromuscular junction, and in myasthenia gravis we have an antibodies that is targeting the acetylcholine receptors or the muscle-specific tyrosine kinase receptors, and they are causing the presenting symptoms. So the antibody-mediated T-cell dependent immunological attack in the postsynaptic membrane and causing abnormality in neuromuscular transmission and presenting with the cardinal feature of myasthenia gravis, which is fatigable weakness. So what are the symptoms? So the symptoms can be ocular, like double vision or diplopia, ptosis, which is usually asymmetric, ophthalmoplegia, difficulty in or asymmetrical eye movement. It can be bulbar with fatigable chewing, dysarthria, dysphagia, and we have weak smile, or what we call it myasthenic phase. We have a respiratory, like breathlessness, weak breathing, respiratory failure, and this is what we considered as myasthenic crisis. We have limb and neck, dropped head. Usually it involves more proximal muscle than distal. We have more of arm more than leg. So how we diagnose? So initially we diagnose the patient clinically with fluctuation of the symptoms in the form of double vision, ptosis, with sustaining the up gaze movement. So we'll ask the patient to look up gaze for 60 seconds, and after that we see that the ptosis is worsening. And also we ask the patient to do repetitive movement of, for example, shoulder abduction, and we induce the fatigable weakness. So here's an example. So initially the patient in the 0 seconds, after that in 10 seconds with up gaze movement, you notice that the ptosis is worsening. And here's the maximum lid closure, lid opening. And after that, after 10 seconds, you can notice the difference between two pictures. In the laboratory, we can do serological testing in the form, we can send for cholinesterase binding antibodies, and we can send also for anti-MuSK antibodies. We can do AMG and nerve conduction study with repetitive nerve stimulation and single fiber AMG. We can do chest CT chest to rule out thymoma, or in case of if it is already resected of any recurrence. Regarding the hydrophonium test or ice pack test, this is a test can be done bedside to stimulate also the fatigable weakness and diagnose the patient. The important to know in terms of factors that can trigger or worsen the myasthenia gravis. So we have a surgical procedure, pregnancy and postpartum surgical procedure, pregnancy and postpartum period, heat, stress, viral infection, bone marrow transplantation, some medication that we should keep in our mind, like some of the antibiotics, like aminoglycosides, tetracycline, penicillins, magnesium and magnesium-containing medication like laxative and antacid, botulinum toxin, interferon alpha, D-penicillaminoase, and some of the cardiovascular medication, some of the anesthetic and neuromuscular blocker. In terms of the management, so for the management, myasthenia gravis, so in the it's highly treatable with immunomodulator. So we can start with corticosteroid and with the long-term immunosuppressive treatment like azathioprine or Cellcept, IVIG or plasma exchange in severe manifestations. For the thymectomy, also it's it showed improvement in the clinical trial. So in the acute management, these are the options available. Pyridostigmine is the most used as acetylcholinesterase inhibitor for symptomatic treatment of myasthenia gravis symptoms, and it's used for symptom management alone in purely ocular or mild cases. And in addition to steroid with pyridostigmine, we can start 60 milligram a day up to 80 milligram a day as tolerated. After that, we should initiate the steroid-sparing agent, and as we mentioned before, or other immunotherapy to avoid long-term steroid management. The last topic for our talk is Guillain-Barré syndrome. So Guillain-Barré syndrome encompasses a group of heterogeneous but related disorder of peripheral nervous system that have acute onset, and almost always it's a monophasic. So it happened usually often post-infectious with paralytic symptoms, and it's an acute, it can be either acute in two most common form: acute inflammatory demyelinating polyradicular neuropathy and acute motor axonal neuropathy. The National Institute for Neurological Disorders and Stroke Diagnostic Criteria for Guillain-Barré. So it's a progressive muscle weakness of more than one limb. The progression of the weakness for 2 to 4 weeks. Usually it's areflexic or hyporeflexia. It's mostly symmetrical, involving mild sensory symptoms and also the cranial nerve. With involvement of autonomic dysfunction, absence of fever, and elevated CSF protein. So in the clinical presentation, they presented with early on with symmetrical sensory involvement or weakness in an ascending pattern of the proximal muscle. So the causes usually can be post-infectious, either gastrointestinal or upper respiratory tract infection. The most common bacterial infections can be Campylobacter jejuni, and it causes also with other viruses like CMV, Epstein-Barr virus, Mycoplasma, and H. influenzae. Also, less common causes like trauma, vaccination, immunosuppressive medication, pregnancy, and post-operative surgery. So investigation, we can do the nerve conduction study and looking for the demyelinating features. Also, lumbar puncture for albuminocytological dissociation, meaning that the protein will be high and the cell count will be normal. And in this case, it helps in the management of initiating IVIG and or plasma exchange as a treatment with monitoring and avoiding complication. So close monitoring of the forced vital capacity, blood pressure, heart rate, and rhythm, and bulbar function is necessary to identify patients with deteriorating respiratory function or autonomic instability, or those at risk of aspiration who require intensive care. So what's the prognosis? A number of factors are considered poor prognostic factor, including the age. If it is more than 40, preceding diarrhea, short interval from the onset to the severity of the disease, need for mechanical ventilation, high-grade deficit on Guillain-Barré syndrome disability scale, and persistent low CMAP amplitude. And the predictability also of two issues is important, the need for mechanical ventilation and the long-term functional outcome. I hope my talk was interesting and not that long. Thank you for listening.